Usually, when you are handed a medical diagnosis, there's a certain, I don't know, a certain comfort in the sheer structural precision of it.
Oh, absolutely. I mean, you break a bone, the x-ray reveals a stark, jagged white line across the radius, and the intervention is purely mechanical.
Right. You just set the bone, you cast the arm.
Exactly. The problem is visible, it's localized, and it's highly categorized.
But the moment you step into the realm of endocrinology, and specifically the incredibly complex landscape of menopause and hormone therapy, that binary framework completely collapses for you.
Oh, it really does.
Yeah, because we are no longer looking at static structures.
Yeah.
We're looking at this invisible, constantly shifting web of chemical messengers and cellular receptors.
And the diagnostic waters just become profoundly murky.
Which brings us to the core biological puzzle we are mapping out for you today on this custom-tailored deep dive.
Yeah, it requires an entirely different diagnostic philosophy.
It really does. So today, our mission is to look past the often intimidating jargon of hormone replacement therapy to explore an incredibly specific dynamic cellular interaction.
Right, because you were suddenly dealing with systemic feedback loops, localized tissue responses, and symptoms that mimic completely unrelated pathologies.
Exactly. We want to understand exactly how systemic bioidentical progesterone creams affect local estrogen receptor responsiveness in thinning atrophic tissue.
And I know it's a mechanism that sounds a bit niche on the surface, but it dictates the daily quality of life for millions of people navigating the physiological fallout of systemic hormone decline.
It's huge. And we've got an amazing stack of sources for this today, too. We're pulling from deep pharmacological breakdowns on stat pearls, data from clinicaltrials.gov, urological guidelines from AUA News, and a bunch of recent medical journal studies.
It's a really comprehensive look at the cellular mechanics.
Yeah, and to really understand the role of a progesterone counterbalance, I feel like we first have to establish the baseline trauma happening in the tissue when systemic estrogen disappears.
Right. And the clinical literature defines this state as genitourinary syndrome of menopause, or GSM.
Right, GSM.
So when a patient transitions into menopause, the tissues of the labia, the vagina, the urethra, and the bladder undergo a severe progressive involution.
Basically a severe breakdown.
Yeah, the structural degradation is profound. We see severe epithelial thinning, meaning the mucosal tissue literally loses its protective layers of cells.
Ouch, that sounds awful.
It is. The collagen framework breaks down, causing a total loss of natural elasticity. And crucially, the localized microbiome collapses.
Because the estrogen isn't there to feed the good bacteria, right?
Exactly. Without estrogen to feed the local lactobacilli, lactic acid production plummets. So the vaginal pH shifts from a healthy acidic baseline to an alkaline state, usually above a 5.
Wow. And the human cost of that structural collapse is just relentless. I mean, patients experience intense localized burning, severe dryness, and despairing of painful sex.
Yeah, and the symptom that creates the most clinical confusion and honestly traps so many patients in a frustrating cycle is the recurrent urinary tract infections.
Oh, this is the trap we saw in the AUA News source, right?
Yeah.
It's wild.
Yes. The diagnostic trap here is one of the most glaring examples of those murky waters we mentioned earlier.
So a patient with USM will walk into a clinic with the absolute hallmark symptoms of a severe UTI.
Right, they have the excruciating burning, the frequent urgency, the pelvic pressure.
And the clinician just logically assumes, hey, it's a bacterial infection, and they run a standard urine culture.
But the culture comes back completely negative. There is no bacterial overgrowth whatsoever.
None at all.
None. The clinical presentation is sterile pyuria. Or, the symptoms are so chronic that the patient gets labeled with a diagnosis of overactive bladder or interstitial cystitis.
And then they're handed endless rounds of broad-spectrum antibiotics, right?
Yeah.
Or bladder suppressants that do absolutely nothing.
Exactly nothing. Because the root pathology isn't an infection or a hyperactive muscle. It is a localized structural collapse.
Man, that's frustrating.
Well, if we connect this to the bigger picture, the tissue of the urethra and bladder trigone shares the exact same embryological origin as the vaginal wall.
Meaning it is incredibly dense with estrogen receptors.
Right. So when estrogen vanishes, the urinary tract tissue thins out and becomes hypersensitive, basically mimicking a severe infection.
The image that perfectly conceptualizes this tissue change for me is think of a simple kitchen sponge left sitting out on a windowsill in the brutal heat of August.
Oh, that's a great analogy.
Yeah, right. After a few days, that sponge is entirely devoid of moisture. It becomes stiff, shriveled, brittle, and highly abrasive.
If you try to bend it, it cracks.
Exactly. That is the reality of estrogen-deprived genitourinary tissue.
Hmm.
But the moment you drop water onto that sponge, the structural matrix plumps back up.
It regains its flexibility, its volume, and its function.
And localized estrogen therapies serve as that essential water, right?
Yeah, precisely. When a patient applies a low-dose vaginal cream, inserts a slow-release ring, or uses a vaginal tablet, that exogenous estrogen binds directly to the localized receptors in the pelvic floor.
And the biological cascade that follows is essentially tissue resurrection.
It really is.
Yeah.
The estrogen receptor complex drives rapid cell proliferation. It physically thickens the epithelium back to its premenopausal state.
Wow. And it triggers local angiogenesis, too, to increase blood flow.
Yes, and it restores the glycogen levels in the tissue,
Yeah.
which, if you remember, feeds the lactobacilli.
So it drives the pH back down to an acidic level.
Exactly, and completely banishes those phantom UTIs. The localized application effectively isolates the therapy to the exact tissue requiring intervention. The sponge is fully revived.
That's incredible. But that sheer proliferative power of estrogen introduces a massive physiological double-edged sword, doesn't it?
It does.
Because if estrogen is this miraculous, life-giving water for atrophic tissue, the logical leap is to just flood the entire system with it to fix all the other systemic symptoms of menopause.
But estrogen is fundamentally a growth hormone for reproductive tissues. Introducing systemic estrogen without a counterbalance is essentially hitting the gas pedal on cellular replication.
And cutting the brake lines at the exact same time.
Perfect way to put it. The clinical consequence of unopposed systemic estrogen in a patient with an intact uterus is endometrial hyperplasia.
Hyperplasia. So the tissue lining the uterus responds to that systemic signal by thickening aggressively and abnormally.
Right. And left unchecked, this chaotic cellular proliferation carries a highly significant risk of mutating into endometrial malignancy.
The cellular mechanics driving this are just startling. I mean, the stap curls and the recent study in the journal Biomedicines broke this down using a hypoestrogenic rat model.
Yes, the rat study. Researchers essentially induced animal menopause, applied a conjugated estrogen cream, and tracked the genetic fallout inside the endometrial cells.
And the estrogen didn't just passively encourage growth.
No, it actively upregulated the expression of cyclin D1.
Which is a protein that forces the cell cycle forward into rapid division.
Right. Exactly. And it simultaneously upregulated VEGF, vascular endothelial growth factor.
Right, which basically commands the tissue to build dense networks of new blood vessels to feed all that rapid new growth.
But the upregulation of proliferative pathways is sort of expected. The truly volatile element of unopposed estrogen is its simultaneous downregulation of tumor suppressor genes.
The data showed a distinct suppression of PTN.
Yes.
And PTN is one of the most critical guardians of the genome. I mean, its entire job is to initiate cellular apoptosis, right? Programmed cell death.
Right. It steps in when a cell starts dividing too rapidly or accruing DNA damage.
So unopposed estrogen is forcing massive, rapid cellular division, building the blood vessels to fuel it, and actively silencing the genetic security guard that would normally stop a tumor from forming.
It creates a highly destabilized, hyperproliferative environment.
Okay, let's unpack this, because that sounds incredibly alarming for anyone currently using a localized estrogen cream for GSM.
I know, it sounds scary, but the urological guidelines draw a very stark, vital line in the sand regarding absorption.
Right, because ultra-low-dose local vaginal estrogen is designed specifically to stay local.
Exactly. It has negligible systemic absorption into the broader bloodstream.
So because it isn't circulating through the body and hitting the uterine receptors, the risk of endometrial hyperplasia from purely localized therapy is incredibly low.
Yes. The clinical mandate for a protective counterbalance triggers specifically when a patient utilizes systemic estrogen.
Like a patch or a pill.
Right. If a patient with a uterus is wearing a high-dose estradiol patch, taking an oral estrogen pill, or using systemic gels, that hormone is circulating through the entire cardiovascular system, bathing the endometrium in growth signals.
And that is where systemic bioidentical progesterone becomes the absolute hero of our cellular narrative.
It really is. It acts as the mandatory physiological brake pedal.
So a patient applies a systemic progesterone cream, relying on transdermal absorption. The hormone passes through the epidermal layers, enters the microvasculature, and circulates systemically.
Right, seeking out hormone receptors in the uterus, the breast tissue, and the central nervous system.
And the pharmacological efficiency of how progesterone actually enters the cell is wild. It's like a masterclass in molecular biology.
It is. Progesterone is a lipophilic steroid hormone. It doesn't require complex surface-level transport proteins to grant it access to a target cell.
Because the cell membrane is composed of a lipid bilayer,
Right.
right?
Exactly. So the fat-soluble progesterone molecule simply diffuses seamlessly across the outer boundary and enters the cytoplasm.
It just slits right through.
It really does. And once inside, it seeks out its specific targets, the nuclear progesterone receptors, PRA and PRB.
So the progesterone molecule binds to these receptors, creating a highly active hormone receptor complex.
Yes, and this complex doesn't just passively block other signals from the cytoplasm. It physically translocates across the nuclear envelope, entering the cell's nucleus, where it binds directly to specific DNA promoter regions.
Wait, so it goes straight to the DNA?
Straight to the DNA. It assumes total command of the gene transcription process.
Wow.
The clinical term for this downstream effect in the uterus is secretory transformation.
Okay, secretory transformation.
The progesterone receptor complex actively reverses the dangerous estrogenic cascade we saw in the biomedicines data.
So it forces the downregulation of the growth-promoting cyclin D1 and VEGF.
Yes, effectively halting the rapid cellular division and the chaotic blood vessel formation,
And crucially, it restores the expression of PTN.
bringing the cellular security guard back online to enforce normal, healthy apoptosis.
That's amazing. It's like if estrogen is a hyperactive construction crew tearing down walls, pouring concrete, and throwing up messy, endless additions to a house.
Oh, I like this.
Systemic progesterone is the city building inspector. The inspector walks straight through the front door, halts the chaos, completely rewrites the work orders, and forces the crew to stop building new structures and actually stabilize and furnish the rooms they already have.
That is exactly what happens. It is a multidimensional regulation of the tissue's homeostasis.
So the progesterone actively shapes the DNA instructions to prioritize differentiation and stability over unchecked proliferation. Okay, so we've established that systemic progesterone is a highly aggressive, incredibly effective anti-proliferative agent in the uterus.
Right.
But this leads to a massive physiological paradox when we look at the cutting edge of GSM treatment in these sources.
This raises an important question, yes.
Because if progesterone acts as the ultimate cellular brake, pedal-stopping growth and halting proliferation, researchers in clinicaltrials.gov are now actively testing its direct application on the already thin, brittle, atrophic vaginal tissue to treat GSM.
I know. Applying a potent anti-proliferative hormone to tissue that is already suffering from severe atrophy and cellular depletion seems entirely contradictory.
It feels like slamming on the brakes of a car that is already stalled out on the highway. Why would you introduce a growth-halting signal to a vaginal wall that desperately needs to grow and thicken?
It's counterintuitive.
Yet there are clinical trials, specifically one actively treating postmenopausal women with 30 milligram progesterone vaginal suppositories that are tracking actual improvements.
Improvements in the maturation index, lowering of the localized pH, and relief from severe dryness.
But how?
Well, this paradox illuminates the sheer localized intelligence of human endocrinology. The biological impact of a hormone is not a universal monolithic command.
So it's context dependent.
It is entirely context dependent. The response is dictated by the specific type of host cell reading the signal.
Okay, so a progesterone receptor in the vaginal mucosa is interpreting the hormone completely differently than a receptor in the uterine endometrium.
Precisely. The binding action is the same, but the downstream genetic cascade varies wildly based on the tissue's unique epigenetic landscape.
Oh, wow.
Yeah, in the endometrium, the progesterone receptor complex triggers that aggressive halt to proliferation to prevent hyperplasia.
Right.
But in the vaginal epithelium, activating those exact same receptors is hypothesized to prioritize structural integrity.
So it modulates the local immune response.
Yes, it significantly reduces localized inflammation and supports overall tissue health without triggering the aggressive growth risks associated with estrogen.
Back to the analogy. The building inspector walks into the uterus and orders an immediate halt to all construction. But that same inspector walks into the vaginal tissue, recognizes a completely different environment, and orders the crew to just clean up the debris and reduce the inflammation.
Exactly. It isolates the therapeutic benefits. And this context-dependent signaling is an absolute lifeline for a highly specific demographic of patients.
Hormone-sensitive breast cancer survivors, right?
Yes. For patients who have navigated estrogen receptor-positive malignancies, introducing even localized ultra-low-dose estrogen into their system is often strictly contraindicated.
Because their oncologists will not risk feeding a potential recurrence.
Right. So for decades, these patients were left to suffer the agonizing structural collapse of GSM with no viable medical intervention beyond basic lubricants.
Which barely helps. But demonstrating that localized progesterone can safely modulate vaginal tissue inflammation without acting as an estrogenic growth signal, that provides a massive quality of life intervention for patients navigating oncology protocols.
It's a game changer.
And the drive to find these targeted, non-estrogen solutions has actually accelerated the development of alternative pharmacological mechanisms entirely, hasn't it?
Oh, absolutely.
Like looking at the AUA News urological guidelines, clinicians are heavily utilizing ospemifene.
Yes, ospemifene circumvents the estrogen problem by utilizing selective estrogen receptor modulation, or SERM technology.
SERM technology.
Right. It's an oral medication that manages a brilliant pharmacological trick.
Tell me about it.
Well, the mechanics of SERMs hinge on the three-dimensional conformation of the receptor complex. When ospemifene binds to an estrogen receptor in the vaginal tissue, it alters the receptor's shape in a way that successfully recruits specific coactivator proteins.
So the tissue reads the signal as an estrogen agonist.
Exactly, triggering the proliferation and blood flow necessary to pump the sponge and reverse the atrophy.
But when that exact same ospemifene molecule circulates into the breast tissue and binds to an estrogen receptor there,
The resulting three-dimensional shape is entirely different.
wait, really? It acts as an antagonist?
Yes. It recruits co-repressor proteins that effectively block the receptor and prevent any dangerous proliferative signaling in the breast. It is highly targeted cellular deceptions,
That is just wild.
isn't it? And another fascinating alternative highlighted in the clinical data leverages the concept of intracrinology.
Right, vaginal DHEA, clinically known as progesterone.
Exactly. Instead of applying a direct active hormone like estrogen or progesterone, the patient applies an inactive precursor molecule.
Oh, I see. So the localized vaginal cells absorb the DHEA directly from the mucosa.
Yes. And once inside the cell, the local intracellular enzymes convert that precursor into the exact minute quantities of active estrogens and androgens required to maintain cellular structure and function.
So the genius of endocrinology is that the entire life cycle of the hormone synthesis, action, and deactivation happens completely inside the individual cell.
It's a self-contained system.
The cell manufactures its own microdose of estrogen, uses it to rebuild its structure, and then immediately metabolizes it into inactive waste before it ever has a chance to leak out into systemic circulation.
It completely bypasses the cardiovascular system, keeping the broader body entirely insulated from hormone exposure.
The sheer localized autonomy of these cells is remarkable.
It really is. Whether it is a SERM selectively modulating gene expression based on tissue topography, a single cell manufacturing its own internal hormone supply from DHEA, or systemic progesterone actively rewriting the DNA blueprint to protect the uterus while simultaneously soothing inflammation in the vaginal wall.
It's incredible. I mean, we are constantly managing a highly coordinated, brilliantly responsive ecosystem of cellular receptors.
So true.
Treating the profound discomfort of GSM isn't a simplistic equation of just adding a missing chemical back into a void. It requires a deep respect for the counterbalance.
Absolutely.
Because, estrogen acts as the essential, life-giving water to revive the atrophic tissue, but it brings the undeniable threat of unchecked cellular proliferation.
And then systemic transdermal progesterone provides the vital DNA-altering restraint to keep that tissue healthy, stable, and safe from malignancy.
But that ecosystem extends far beyond the boundaries of the genitourinary tract.
Oh.
Yeah. When we evaluate the pharmacological reach of systemic bioidentical progesterone creams, we have to account for its metabolic journey, because progesterone is a highly potent neurosteroid.
Meaning it effortlessly crosses the blood-brain barrier.
It does. Once systemic progesterone enters the brain, it is broken down into specific metabolites, the most critical being allopregnanolone.
Allopregnanolone.
Yes, and this metabolite acts as a highly effective positive allosteric modulator on the GABA-A receptors in the central nervous system.
Wait, the GABA-A receptors, aren't those the brain's primary inhibitory signaling pathways?
They are. They are the exact same neuroreceptors targeted by benzodiazepines and powerful anti-anxiety medications.
Wow. So by binding to those receptors, allopregnanolone alters their structural shape. Yes, significantly increasing the influx of chloride ions into the neurons. This effectively depresses central nervous system activity, creating a profound anxiolytic and sedative effect.
That is wild.
I want you to consider the sheer interconnectedness of that mechanism. A patient applies a transdermal hormone cream primarily to act as a localized brake pedal on the cellular lining of their uterus.
Right, for the local pelvic tissue health.
Yet, because that hormone enters systemic circulation, its metabolites cross into the brain and fundamentally shift the baseline activity of the central nervous system's calming receptors.
It completely reframes how we view physiological side effects. I mean, you are utilizing a cream to protect the structural integrity of your pelvic floor, and in the process, you are inadvertently rewiring your brain's stress response and neurological baseline.
You cannot isolate a single biological system without causing ripples across the entire organism.
Yeah, from the DNA transcription inside a single vaginal cell all the way up to the anxiety centers of the brain, the signaling web is just absolute.
It's a fascinating reminder.
It really is. Something to think about the next time you consider the sheer systemic power held inside a simple transdermal cream. Thanks for diving deep with us.